I'm John Strum, and this is Real Talk MS. It's September 6th, and we have a lot to talk about. And today we're talking about how you should be talking about your MS treatment plan with your neurologist, nurse practitioner, or MS specialist. The conversation between a doctor and patient is evolving. We're transitioning from a time when that conversation was usually limited to the doctor prescribing a particular disease-modifying medication and the patient nodding their head in agreement to something called shared decision-making, a real conversation that offers the patient an opportunity to discuss their treatment goals, to communicate what their preferences might be, to talk about their risk tolerance, their comfort level with side effects, and other important considerations that need to be made when starting a new therapy. Shared decision-making also gives the doctor or nurse practitioner an opportunity to explain why they're recommending a particular medication and how that medication aligns with the patient's goals. It's pretty easy to see that when a patient is involved in the decisions about their disease-modifying medication, it's much more likely that they're going to adhere to that treatment plan. And that adherence is what promotes the best possible outcomes. But frankly, not everyone has gotten the memo about shared decision-making. There are still plenty of doctors going about their clinical appointments exactly as they have since they graduated from medical school. And there are patients who are wondering what sorts of responsibility shared decision-making places on their shoulders. As you might imagine, it's important that both patients and their doctors need to be on the same page, or we end up with unnecessary awkwardness and even frustration during your clinic visit. My guest today is Dr. Marijean Buhse. I met Dr. Buhse just a few months ago at a conference where she delivered what I consider an outstanding presentation on shared decision-making. And I'm thrilled that she can join me today to walk us through how shared decision-making works and what to do if it's not working for you. But before we get to my conversation with Dr. Marijean Buhse, there are a few other things that you should know about. About 10 days ago, the National MS Society hosted a webcast to explain how and when the recently passed Inflation Reduction Act will have an impact on the cost of your MS medications if you're on Medicare. If you missed the webcast, a replay is available on YouTube. And the MS Society has also created a very handy one-pager that clearly explains the timeline for when you'll see those changes and how much you pay for your medications. I'll include a link to both the video replay of the webcast and that one-page explainer in today's show notes. And if you happen to have the free Real Talk MS app installed on your iOS or Android smartphone or tablet, you'll find that one-pager waiting for you under the bonus content tab. For a long time, MS was considered to be a disease that affected middle-aged white women. Today, we know that's never been true. Yet today, members of minority communities still face challenges when it comes to accessing care or even being diagnosed with MS. Mounting evidence continues to illustrate the health disparities, inequities, and social determinants of health that impact members of underserved communities who are living with MS. In an effort to increase outreach and focus support on members of the Hispanic and Latinx community who are living with MS, the National MS Society is hosting the Hispanic Latinx MS Experience Summit on September 15th. This virtual interactive program will offer participants an opportunity to connect with others in the Hispanic Latinx community, learn from leading experts in research and health, and give voice to the unique needs of the Hispanic Latinx MS community. The program is being offered at no cost in both English and Spanish. It provides participants with a safe place to raise awareness and network in order to better face and overcome the daily challenges of living with MS. If you're interested in finding out more about the Hispanic Latinx MS Experience Summit, or you're ready to register for this event, you'll find a link in today's show notes. It's become clear that COVID-19 is going to be a part of our world for the foreseeable long-term future, which makes it increasingly important that patients and clinicians understand how those disease-modifying medications that modify the immune system affect a person's ability to fight off COVID-19 infection. Research has already shown that people on one of the B-cell depleting therapies don't mount a sufficient antibody response to the COVID-19 vaccines. And as we discussed in last week's podcast episode, we're also learning that there does seem to be a T-cell response to the vaccines. But what we don't have is a more thorough understanding of the long-term effect that these vaccines have on both antibodies and T-cells. That's why it's particularly good news to hear that iConquer-MS, the People-Powered Research Network, has begun a 2-year collaboration with Quest Diagnostics and the National MS Society to study the immune response to COVID-19 vaccines among people living with MS. The study will follow 300 people with MS who are already participating in the iConquer-MS Cover MS project, which is collecting a broad range of data on the effects of COVID-19 vaccination on people living with MS. Quest Diagnostics is providing the laboratory analysis for the study, as well as using its 2,100 patient service centers located across the United States for specimen collection. The results from this study will not only add to our body of knowledge when it comes to understanding how the COVID-19 vaccines affect people living with MS, but may also help fine-tune the guidelines for the dosing and timing of vaccines and disease-modifying therapies for people on those therapies that have an impact on the immune system. And I might add, this very economical and efficient method of sample collection, leveraging the convenience of local Quest Diagnostics patient service centers, might also serve as a proof of concept that can inform future studies. This is all good news that we'll be following as the study continues. Repairing the myelin that's been damaged by MS is the key to restoring the physical function that's been lost. And judging from the number of emails that I've received, this is, quite understandably, a topic of major interest in the Real Talk MS listener community. So over the past year, we've talked a lot about some of the research efforts that are currently focused on exploring remyelination. Scientists at the University of Chicago have shown that a derivative of a hypertension drug might be repurposed to prevent myelin loss. A research team at the University of Maryland School of Medicine has identified stem cells in hair follicles with a specific surface protein that was shown to repair myelin in mice. Biotech company Autobahn Therapeutics has announced a lab-created molecule that's been shown to promote myelin repair in the animal model of MS. And now researchers at Oregon Health and Science University have identified something found in fruits and vegetables that, once modified, has been shown to create new myelin in mice with the mouse model of MS. Flavonoids are chemicals found in fruits and vegetables, and the research team modified a specific flavonoid to create a drug they're calling S3. Now, in understanding how this drug does what it does, we need to take a step back first to review some basics. The cells that are responsible for forming myelin are called oligodendrocyte progenitors. That's a long name, and frankly, the name isn't important, but the function of oligodendrocyte progenitors is very important. Back in 2005, an Oregon Health and Science University professor and a past guest on Real Talk MS, Larry Sherman, and his team found that the accumulation of a molecule called hyaluronic acid in the brain inhibits these oligodendrocyte progenitors from forming myelin. You can actually see this occurring in the mouse model of MS and in the lesions of humans who are living with MS. The researchers identified a family of enzymes that degrade hyaluronic acid, and they later discovered that these fragments of degraded hyaluronic acid were instructing those immature oligodendrocytes myelin genes to stay inactive. The research team hypothesized that if they could find a way to block that activity, this degrading of hyaluronic acid, they could promote remyelination. Those oligodendrocytes would no longer be receiving that instruction to stay inactive. So using S3, this drug they derived from a modified flavonoid, the scientists observed that the hyaluronic acid was no longer being degraded, and so it was no longer instructing the oligodendrocytes to remain inactive. The result was remyelination in the mouse model of MS. Now, there's still plenty of work to be done here. I'll share my usual reminder that there's a vast difference between the mouse brain and the human brain. Nonetheless, this study represents a step forward in understanding aspects of remyelination. As Dr. Sherman points out, the mouse studies show that this approach can work. What remains to be determined is whether S3 can be adapted to work in human brains. As I mentioned a moment ago, there's a lot of research currently underway to determine the most effective pathway to myelin repair. So you can be sure that this is a topic we'll continue talking about as progress continues to be made. And if you'd like to review the details of this study, you'll find a link in today's show notes. We've long known that the further one lives from the equator, the more likely they are to develop MS. This is something that's often been attributed to the amount of vitamin D exposure we receive from the sun. However, results of a study from Johns Hopkins University School of Medicine may offer an alternative explanation for this phenomenon. In fact, the results of this study force us to reconsider how we think about the rate of MS in the world. Now, the research team first analyzed data from a variety of studies and existing databases to determine the rate of MS in 203 different countries and territories. Then they grouped these 203 countries by geographic region and by income levels. They discovered that rates of MS varied by region and by income level, finding in high-income countries an average of 46 out of every 100,000 people were living with MS, compared to 10 out of every 100,000 people who were living with MS in low-income countries. They also calculated per capita healthcare spending in high-income countries to be $2,805, compared to just $45 per capita in low-income countries. In their analysis, the researchers were able to account for other factors that could affect the risk of MS, including age and sex. After incorporating these various factors into their analysis, the research team still found that healthcare spending was strongly associated with the rate of MS in any given country. They further demonstrated that as healthcare spending increased from country to country, the rate of MS increased. The availability of universal health care in a country was also statistically tied to higher rates of MS. So, what might this data mean? Demonstrating the link between higher expenditures in healthcare and higher rates of MS suggests that greater investment in healthcare means more neurologists per capita, more technology, more MRI availability, and greater opportunity to actually diagnose MS, which could mean that MS rates in low-income countries may be significantly underreported. It may not be the amount of sunlight these countries receive. It may be fewer qualified healthcare professionals and facilities capable of making an MS diagnosis. And if this is the case, it's a problem without easy solutions, but still a situation worth noting in trying to understand the difference in the rate of MS from one country to another. And if you'd like to review the details of this study, you'll find a link in today's show notes. If you're a regular listener, you know that I like to report on outcomes. And I want to update you on a great outcome and give a shout out to the folks at A&W in Canada. This past August 18th marked the 14th annual Burgers to Beat MS fundraising event, where A&W donated $2 to the MS Society of Canada for every teen burger sold that day. And this year, they beat their goal of $1.5 million by raising $1.8 million, bringing the total amount raised by A&W over the last 14 years to over $19 million. Canada has one of the highest rates of MS in the world, and this annual event goes a long way toward raising awareness, providing support to people living with MS in Canada, and supporting MS research. So a big thank you goes out to A&W Canada and the team at the MS Society of Canada who continue to make this event such a smashing success. Making your MS treatment a success also takes a team, with the patient at the center of that effort as an active participant. Good outcomes are the result of effective shared decision-making between a healthcare professional and patient. In a moment, we'll meet my guest, Dr. Marijean Buhse, when we explore what shared decision-making is all about and how you can ensure that your MS treatment plan is the result of effective shared decision-making.
There isn't one disease-modifying therapy that's going to be the ideal treatment for everyone living with MS. And the good news is that today there are more than 20 DMTs that have been approved by the FDA to treat multiple sclerosis. But with so many options, how do you go about choosing the right medication for you? My guest today is Dr. Marijean Buhse, and we're talking about how you can work together with your healthcare provider in shared decision-making when it comes to determining the best MS medication for you. Dr. Buhse is a clinical professor at Stony Brook University School of Nursing and a nurse practitioner at the Comprehensive MS Center at South Shore Neurologic Associates. Dr. Buhse and I had a brief conversation about shared decision-making while I was attending the Consortium of Multiple Sclerosis Centers annual meeting last June. I think it's an important topic that needs to be discussed and explained more often, and I'm excited to have her join me today for a deeper dive into how this adjustment to the traditional doctor-patient relationship can lead to better outcomes. Welcome back to the podcast, Dr. Buhse.
Thank you, John. Pleasure to be here.
Before we get to shared decision-making itself, I'm hoping you can clear up some confusion that I know some people living with MS get caught up in. Disease-modifying therapies available today mitigate the inflammatory process associated with MS. They're designed to preserve more myelin longer, so disability progression is slower. They aren't specifically designed to address the symptoms of MS. What sometimes happens is someone begins a DMT, they don't see their symptoms improve, and so they decide to stop their DMT because they aren't getting quote-unquote better. Can you talk about why starting a disease-modifying therapy early is important and why staying on treatment really matters?
Yes. Thank you for that question. It's a very important question. So starting disease-modifying therapies early is so important to the person with MS and their disease. We know from more than 20, maybe close to 30 years of disease-modifying therapies that the look of MS has changed. The nature of MS has changed. It used to be that others before me would diagnose and say, adios, there's nothing we can do, MRI and goodbye. There was nothing we could do. But now we have seen that instead of patients becoming disabled, using a cane, I think most of the studies showed that there was a cane use within 15 years of the diagnosis, and perhaps a wheelchair within another 10 years. So if you're thinking about someone who was diagnosed at age 25, by 40, they're using a cane. By 50, they might be in a wheelchair, and the disease just progressed. Now we know with these disease modifying therapies, we have slowed that progression remarkably. And we have also changed the fact that patients don't get so many relapses anymore. And they also do not get progression and lesions on the MRI as frequently as they used to. So the whole look of MS has changed in the past 20 years.
I mentioned a moment ago that I met you at the Consortium of MS Centers annual meeting when I was in the audience listening to what I want to say was your outstanding presentation on shared decision making. So maybe a good place for us to get into today's conversation is for you to define what shared decision making is.
Yes, and I'd like to do that. Shared decision making is when both healthcare providers and patients work together to look at the best evidence and decide what's the best medication for that patient, and we decide together. So the healthcare provider, and when we're opening it up to shared decision making, first of all, we introduce choice. And one thing we never do is introduce 20 or 21 choices. I generally will look at 2 or 3 choices for the patient. My thought is, this is what the patient's MRI looks like. This is what their blood work looks like. This is what they look like. Okay, let's get together and talk about these choices. Now, if a patient comes to me and says, no, I don't like those 3, I want this one, then we're going to have that discussion too as to why I agree or why I may not agree. But ultimately, it is the patient's choice to decide what medication that they're on. We want them to have the best evidence. We want to describe the options. I want to help you explore and decide your preferences. And then I want us to make a good decision together.
Why is shared decision making particularly important to someone living with MS?
Well, the reason for that is because MS is a disease, a lifelong disease, and many people are diagnosed between the ages of 20 and 40. And so the healthcare provider has a very long relationship with that person. And unlike your primary care provider, I see my patients every 3-4 months, and I get to know them, and I have a full relationship with them. So they have to be willing and ready to talk to me about any problems that they may have, new symptoms that all of a sudden popped up, depression, anxiety, anything that's bothering them. They have to be able to talk to me about it. And as the healthcare provider, it's important that I listen and that I help solve those problems. I love it when my patients come to me and say, you prescribed that drug and I don't have that feeling anymore. I'm like, hallelujah. It's always a good day. So that doesn't always happen, but we do try to make that happen.
Some people with MS worry that they have to become experts in all those 21 disease-modifying therapies so they can make the best decision in choosing a DMT for themselves. Can you put those worries to rest?
Yes, absolutely. You can't be an expert in 21. I can't be an expert in 21 disease-modifying therapies. First of all, just to be aware of it, many of the disease-modifying therapies, at least 5 of them, are very similar to each other. And then we have other medications in another class that are similar to each other. So the classifications of the medications can be very similar all around. But what's most important is the medication that is best for you. And that medication is the one you stay on. If you won't stay on it, it's not a good medication.
You know, speaking of becoming an expert, when patients go online and Google multiple sclerosis, they can connect to what seems like an endless, infinite amount of information. Some of that information is really good. It's really helpful. Some of that information isn't too credible. And some of that information sounds a little crazy. But it all seems like expert information. When we talk about shared decision making, what happens when someone has, with the best of intentions, done their homework online and happens to get caught up in some information about potential MS treatments for which there's no evidence, no support, not even a good idea from a health point of view, they come to see you. What's that conversation that you need to have with them?
Well, I think it depends upon a couple of items. First of all, I was around when bee stings were very popular, and people would sting themselves with bees thinking that the bee venom was going to help their multiple sclerosis. Now, there was no studies available about that. There's no data to show that that even worked, but people believed in it. And so what I would say to my patients, okay, you could sting yourself with bees as long as you take this medication that I'm prescribing also. And I do say that about many of the herbal medications that people decide. I don't have a problem with this. I'll go through their list of herbal medications, but also remember that the person at the healthcare store, I probably have a better idea of what MS is and what's important to MS than they do. Many people just say, oh, the guy at the healthcare store told me this. I have a lot of degrees and I think a lot of experience in MS. So I think perhaps listening to your healthcare provider might be a better idea. However, some of the herbal things that you could take are good. And I say, yes, take them, but take this too, because this is going to change the course of your disease. It won't cure it. We don't have a cure yet. People are working on a cure, but it will change the course of your disease. And I think that's vitally important.
Starting a disease-modifying therapy can mean dealing with the very high cost of MS disease-modifying medications. It can mean dealing with potential side effects, and it means considering risk factors. So it's not unreasonable to think that someone who's initially experiencing mild MS symptoms, someone who's newly diagnosed, they may decide not to start a disease-modifying therapy. As you've already mentioned, there's plenty of evidence that shows the importance and the benefit of starting on that DMT as early as possible. How do you approach that conversation with a patient when the two of you aren't on the same page?
Yeah, and I find that a very difficult conversation because I'm very open with my patients and I say, I show them the MRI, I show them everything. And I do have some patients, not a lot, but some patients who say, I'm going to try diet first. I'm like, well, this is not heart disease. It won't change. You could try diet, but I'd like you to try this too. Oh no, I'm changing I'm changing my diet. Now the problem with MS, and I have one clear person in my head, the problem with MS is that you have a bad relapse and then you get better and you think it's because of the diet, not because MS gets better. Initially, the relapse goes away and people get better. So education about what MS is and what MS does is vitally important. But the other thing is frequent communication with people who won't go on drug, because once they have that second relapse and it's a mess, they're sorry. And we don't know, we can't predict when that'll happen, but we really want people on drug. And that's what MS centers do. That's what we focus on. We focus on MS. So we focus on getting people on the appropriate drug that they want and they will stay on each time.
For some healthcare providers, shared decision-making is a different approach to treating their patients. Not every healthcare provider embraces shared decision-making, and there are some, especially general neurologists who aren't part of an MS center or who are not MS specialists, who haven't even heard about it. So what happens when a healthcare provider isn't accustomed to including the patient in treatment decisions? How can a patient advocate for themselves to be a part of that conversation?
So one of the most important things that I believe that any patient should feel about their healthcare provider is that they can have a good conversation with them. And they can say, I think this medication versus this medication, and not be told you don't know what you're talking about. Because if that, or if that person says, I don't feel comfortable giving you that medication, well, tell me why. Sometimes if you're not a specialist in that area, you don't really understand the ins and outs of that drug and why that may be a side effect, but that is also the way the drug works. So for instance, there are some drugs that that are on the market, and they're very good drugs. And the mechanism of action is to keep the lymphocytes, which are white blood cells, low in the body. So I have had general practitioners call me and say, "What did you put this patient on? The white blood cell count is low." And I said, "Well, that's the way the drug works." "Oh, I didn't know that." So these are things that if your provider is not aware of, and you feel uncomfortable, then I think it's time to find somebody you feel more comfortable with, because this is a lifelong disease and you're going to be together for a long time.
Well, Dr. Marijean Buhse, thank you for all you do to improve the lives of people living with MS. And thanks for talking with me today.
My pleasure, John.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/262. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.